We have done a lot of radio interviews, podcasts, and public health seminars to create awareness about the impact of untreated hearing loss. To date, 9 masters in audiology, 9 honors, 4 Ph.D., 4 postdoctoral researchers have contributed to the work that I'm going to share with all of you here today. First, let's talk about healthy aging. So in 2022, 52 million Americans were 65 years and older, and by 2050, that number is expected to rise to 82 million, in about 47% increase. So what does this mean? This means that the majority of the people that we see in our clinical settings are old adults. So it's really important for us to understand the impact of hearing loss in healthy aging. So, according to World Health Organization's ICOP model, there are 6 components important for healthy aging. These include visual capacity, hearing capacity, cognitive capacity, psychological capacity, locomotor capacity, and vitality. Therefore, hearing plays a significant role in healthy aging in old adults. I'm sure everyone is very familiar with the statistics on, information on hearing loss. Just to reiterate, hearing loss affects 1.3 billion people globally. 70% of the adults aged 70 years and above have a hearing problem. People start using hearing aids when they're around 70 years of age, but usually it takes about 9 years for them to seek help. Hearing aid uptake is quite poor. Only 1 in 3 who would benefit from them use them. So, if we look at the old adults in a clinical settings, we are not only seeing people who do have a hearing problem, but we see people who are at risk of cognitive impairment and dementia, physical frailty, depression, anxiety, and stress symptoms, social isolation, and loneliness. The first topic I'm going to talk about here today is about the impact of hearing loss on psychosocial well-being. When we talk about psychosocial well-being, there are 2 terms that are that we need to know about. The first one is social isolation. Social isolation refers to having limited relational network and social contacts. However, loneliness, it is this unpleasant feeling we get from the discrepancy between desired and existing social relationships. So, loneliness can further be divided into social loneliness and emotional loneliness. And both social isolation and loneliness are risk factors for cognitive impairment and dementia. So, we conducted a community-based study to understand the association between hearing loss and psychosocial well-being. We recruited 202 participants. They all completed hearing assessment, social and emotional loneliness questionnaire, and social support and interaction questionnaire. So when we looked at the results, we saw a significant interaction between aging and hearing, and we saw poor social interaction scores seen for people who were not only older but with poor hearing. Living alone, depression, and stress had a significant impact on social loneliness. Then we also saw a relationship between emotional loneliness and hearing loss. As the severity of hearing loss increased, we saw an increase in emotional loneliness. So what do these results mean? So as people age, aging reduces the number of social contacts and declining social activity. And if someone has a hearing loss and the hearing loss imposes a lot of demands on the communicating partners. For example, they will have to speak slowly, exaggerate their articulatory movements, move closer to the listener, and repeat conversations. So that could lead to being a bit frustrated or annoyed. So therefore, people tend to make less contact with people with hearing loss. So even if someone with a hearing loss, sitting at a dinner table surrounded by very loving and caring family members, if they can't have a meaningful conversation, and if the communication is broken down, they could feel emotionally lonely. So the next topic I'm going to talk about is mental distress. We were very interested in understanding the association between hearing loss and mental distress. So first we did a systematic review and a meta-analysis. In this study, we looked at 35 studies, which had about over 140,000 people. So the results revealed that hearing loss has 1.4 increased odds of depression. Mild hearing loss had a 32% increased risk for anxiety, and moderate hearing loss had 59% increased risk of anxiety. Then we went back to our community and recruited people from the community, and we asked them to complete a hearing assessment and depression, anxiety, and stress -21 assessment. We wanted to investigate the association between hearing loss and depression, anxiety, and stress. So when we looked at the results, we saw that hearing loss was associated with clinically significant depression, anxiety, and stress scores. So then the next logical question for us to ask was, what happens to mental distress when we treat hearing loss? So we did two studies. One study looked at the hearing aid users, the other study looked at the cochlear implant recipients. So the hearing aid study had two normal hearing listeners, hearing aid users, and participants with a hearing loss. We looked at the DAS scores at the baseline, 3, 6, and 12 months. So when we looked at the results, we saw that those with normal hearing had their depression, anxiety, stress scores within normal range. However, when we looked at those who had a hearing loss, their depression, anxiety, and stress scores increased over time, and they were clinically significant. But the hearing aid group had relatively low depression, anxiety, stress scores, and they were within the normal range, and they were stable over 12 months. Then we looked at the cochlear implant recipients, their depression, anxiety, and stress scores over time. Compared to the normal hearing listeners, cochlear implant recipients had higher levels of depression and anxiety scores. So we went back to the participants, and then they asked questions whether they were aware of having high levels of depression scores, or we asked the clinicians, and the participants weren't aware of having high levels of depression scores, and the clinicians weren't aware of that either. So when it comes to cochlear implant recipients, after the implant surgery, that's the time they go through their rehabilitation. So having high levels of depression could have affected the outcomes of with their implant device. So how can we help people who have a hearing problem and also have high levels of social isolation, loneliness, or mental distress? So first of all, as hearing care providers, the first responsibility to help them manage their hearing loss using suitable devices. And then it's really important to create an awareness around the training for communication partners so they can support the person with the hearing impairment. And also direct them towards, if there are peer support groups, direct them towards peer support groups to help them reduce social isolation and loneliness. So hearing aids, cochlear implants, hearables, these devices, we can't really rely only on these devices and intervention to improve psychosocial outcomes. A peer support group seems to help improve well-being of the community members. So what we did was we did a study to find out by creating online community whether that would help people with hearing impairment to provide this peer support that they needed. So we first did a community conversation. We went back to the community members and asked them, what is the most the social media platform that you all use most of the time? And then it was revealed that they use Facebook. And then we asked them, if you were to create an online community, how can we make it more user friendly? What are the topics that you want for us to, share? So based on the feedback we got from them, we created an online community using the Facebook group. It was a moderated, closed online community. So once we've done our online community, we sent out the invitations through hearing clinics in Western Australia, and those who provided the consent were allowed to join the community. Once they joined the community, we requested them to complete a set of questionnaires, because this is, of course, a research study. We wanted to know the outcomes of the online community. They completed a demographics questionnaire, self-assessment of communication, 12-item short form survey, a questionnaire on depression, anxiety, and stress, a questionnaire to assess emotional, social loneliness, and social support and interaction. Once the participants completed the survey, we monitored we asked them to redo the survey at 6 and 12 months' time, that we used for quantitative analysis. And then after participants actively participated in the online community, and we also did something called, we did a qualitative data analysis using ethnographic methods. So when we looked at the results, we saw that poor communication scores correlated with poor physical and mental health. Poor communication scores also correlated with the high levels of depression, anxiety, and stress scores. Poor communication scores correlated with the poor emotional loneliness, but not with social loneliness. Then we looked at the comments and posts made by participants. We identified the codes and we looked at the common themes. So when we looked at the common themes, we came across themes such as challenges experienced, community engagement, coping strategies, empowerment, and so on. For example, one of the participants said, I always dreamed of being a pilot, but as an adult, was told that I couldn't do it because my hearing was insufficient. When I was 29, I got my hearing tested for aviation standards and passed. So people were quite vulnerable and started sharing their challenges, the experiences and coping strategies they used. And we could see this online community became a really nice support group for people and empowered them. So, as with any other research study, we also had some limitations. Not all participants completed the online questionnaire. Some people didn't want to use the Facebook. They had some security concerns. So, at the end of the project, we asked for recommendations from our participants, and they said that touchscreen devices and then workshops on how to use social networking on training programs could help them participate actively in the online community. The take-home message from this project is that we have to look at the overall bigger picture. Treating hearing loss using the devices is also really great. However, we also need to provide additional support using communication training and support from peers. The next topic I'm going to talk about is frailty. When it comes to old adults, frailty and falls, these are the things that we kind of hear in our clinical settings. So we consider someone to be frail if they exhibit three or more of the following symptoms. If they have lost a lot of weight and if they're exhausted all the time, they have very poor grip strength and walk slowly, have low physical activity, we consider them to be frail. And hearing loss is considered an important marker in frailty. So one of my former PhD students looked at the association between hearing loss and frailty. We did a systematic review. First, we looked at about, I think, 4,000 um, manuscripts, published manuscripts that looked at the association between hearing loss and frailty. And the results revealed that hearing loss was associated with 73% increase in the risk of frailty among cross-sectional studies and 56% among longitudinal studies. Then what we did was we have a longitudinal study in Western Australia. We call it HIMSS, or Health in Men study. So we looked at the data from Health in Men study. We looked at participants aged 70 years and above and who were free of frailty at the beginning of the study and looked at their data for 17 years. In this study, hearing loss was defined by self-report or diagnosis recorded in the Western Australian data linkage system, and the incident frailty was assessed using hospital frailty risk score. So during the follow-up, around 70% of the men developed frailty. And then we looked at the results. We saw a trend that men with hearing loss were more likely to develop frailty compared to their normal hearing peers. So we wanted to find out the impact of treating hearing loss using hearing aids on frailty. So we conducted a clinical trial, and the results have been recently accepted, not yet being published. So I hope by next week we'll have the published results to share with everyone. So the results are quite interesting. So the last topic I'm going to talk about today is hearing loss and dementia. As you all know, every 3 seconds, someone in the world develops dementia. Looking at the Australian statistics, currently 400,000 Australians diagnosed with dementia. It is the highest cause of mortality among Australian men and the second highest cause of mortality among Australian men and highest cause of mortality among Australian women. And hearing loss is considered one of the highest modifiable risk factors for dementia. Now it's tied with LDL cholesterol. It's when we, as clinicians, when we talk about hearing loss being a risk factor for dementia, it's important to remember that this risk factor differs between countries and within population groups. So, how does hearing loss lead to cognitive decline and dementia? There is no causal relationship, but we can see an association between hearing loss and cognitive decline and dementia. There are a number of factors could contribute to it. One of the factors is increased listening effort, increased cognitive load. And also hearing loss lead to functional modifications of the auditory pathway and the brain. You all heard, that I shared some information about the impact of hearing loss on social isolation and depression. Hearing loss is a risk factor for social isolation and depression. In addition, there are common etiological risk factors such as aging, diabetes, heart diseases, inflammation. Together, all of them increase the risk of cognitive decline and dementia. So, how does one going through healthy aging process, end up with dementia? Aging is a complex process, and when people age, sometimes people start exhibiting a lot of memory issues. They forget where they left their car keys. They forget people's names, and if they exhibit increased number of memory complaints, we call them either subjective memory complainers or subjective cognitive decline. So if we conduct a cognitive screening assessment at this point with those who exhibit higher number of memory complaints, they will perform really well in that cognitive screening test. So some of the people who go through subjective memory complainers or go through the normal aging process move into the next stage we call mild cognitive impairment. It could be due to um, Alzheimer's disease or factors that are unrelated to Alzheimer's disease. So during the mild cognitive impairment stage, we conduct a cognitive screening assessment. We are going to see poor scores. However, they will be able to attend to their daily living activities really well. The next stage is dementia. Dementia, there are many factors that could contribute to dementia, and Alzheimer's disease is now number one cause for dementia. So at dementia stage, if we look at their cognitive scores, they perform really poorly. If we look at MRI or PET scan, we can see the changes in the brain pathology. And also, if we look at their daily living activities, they perform really poorly. They can't look after themselves. That's where they need more support. So we've done quite a bit of work related to hearing loss and dementia. We have looked at peripheral hearing loss as well as central auditory processing. When we looked at the data from our Health in Men study, we looked at a sample of 37,000 old men, and we saw an association between dementia and peripheral hearing loss. We also have seen an association between hearing loss and nonverbal cognitive impairment. And we also have seen poor central auditory processing scores in those who have mild cognitive impairment and dementia. In one of our studies, we also have seen that those who have subjective memory complaints with normal hearing also show poor central auditory processing. So central auditory processing is impaired in people diagnosed with Alzheimer's disease and its preclinical stages and may manifest many years before a formal clinical diagnosis. So the next question is, what can we do as hearing clinicians, as hearing care providers? What can we do to support people who are at risk of dementia? The first is empowering the audiologists to talk about memory issues, and then providing the clinicians with suitable clinical tools for assessments and rehabilitation. And then we talk about whether clinical interventions can help. So the first topic about the empowering audiologists to talk about memory issues, we did a survey. We call it a knowledge, attitude, and practice survey among Australian hearing clinicians. Later, we have extended the survey to 9 countries. In this study, we looked at the knowledge, attitudes, and practice of hearing healthcare providers in supporting old adults at risk of dementia. The results reveal that 60% of the clinicians never received any training in administering cognitive screening. 90% of them never conducted a cognitive screening. When we talked about assessment and rehabilitation, 19% of the participants of this study agreed that they should provide extra support to those who have been diagnosed with hearing loss and dementia. But however, 43% didn't know how to incorporate cognitive support in hearing rehabilitation. When it comes to practices, 90% of the clinicians agreed that they should refer clients with suspected memory issues to the GP or other healthcare professionals, but 73% didn't know the referral pathways. So this study highlighted that there's need for training, clinical guidelines, and practices so the clinicians can better support patients who are at risk or diagnosed with dementia. So when it comes to clinical assessments, around 50% of the people diagnosed with dementia aren't able to provide reliable responses, subjective responses. So in that situation, it's really important to incorporate objective hearing assessment to establish hearing thresholds, such as ASSR or tone-based audiometry or clinically evoked response audiometry. However, in our clinical practice, what we have seen is when people are diagnosed with dementia, especially in about moderate stages, it's really not that easy to conduct the objective hearing assessments too, because they get anxious. At that stage, you're going to see a lot of behavioral problems, and they wouldn't like the electrodes, and the cords and the wires hanging around. So, um, we have established industry collaboration through which now we are working with Curtin University engineering team to come up with a simpler test that can be administered in aged care settings, easily administered in aged care settings, so we can obtain information about hearing thresholds. The other challenge we come across is when it comes to rehabilitation. When it comes to providing hearing aids, usually clinicians can, to some extent, rely on real ear measurements or REMs to program the devices. Similarly, for cochlear implants, also, some of the manufacturers have incorporated objective methods through which the cochlear implants can be programmed. So in this study, we used metal cochlear implants, and we used the electrically warped stapedius reflex threshold test to find out whether we can use ESRT to create objective maps. So two of the masters in audiology students did this project. So we didn't see any significant difference between subjective maps created based on feedback of the people and the objective maps created using ESRTs in people with normal cognitive functions and those who were diagnosed with NCI. So ESRT also can be used to create objective cochlear implant maps. Then clinical interventions. So we need more information to draw conclusions that by treating hearing loss using hearing aids can delay the rate of cognitive decline in old adults. To date, there are only 2 clinical trials have been conducted. One is the Achieve trial conducted by Franklin and his team, and I'm sure you all are very familiar with that. Second is the HearCog clinical trial that my team and I have just completed. So just to reiterate the findings from Achieve study had 2 participant groups, ARIC community and community healthy de novo community. In this study, the participants were between 70 to 84 years old. They had a hearing loss and they did not have any cognitive impairment. So the intervention included 50% of the participants receiving a hearing intervention using hearing aids, and the remaining 50% received health education. When you look at the combined results of both communities, the hearing intervention did not reduce 3-year cognitive scores of the total cohort. However, when they did a sensitive analysis, between the groups separately, they saw a change in cognitive scores of the atherosclerosis or the ARIC community. So the conclusion that was drawn from that clinical trial is that hearing intervention might reduce cognitive change over 3 years in populations of old adults at risk of cognitive decline, but not in populations at decreased risk for cognitive decline. So to share a little bit of information about the HearCog trial. So this trial is quite complementary to the Achieve study because in this study, we looked at the participants who not only had hearing loss, but also diagnosed with mild cognitive impairment, and they were at risk of dementia. So we wanted to find out whether hearing aids decrease the 24-month rate of cognitive decline. And in addition, we also wanted to find out whether hearing aids have an impact on memory and executive functions, anxiety and depression symptoms, quality of life, physical health, and health-related costs over 20 months. So we recruited 180 participants, 90 in the experimental group and the 90 in the delayed control group. They all completed a global cognitive assessment and nonverbal cognitive assessment. These cognitive assessments are suitable for those who have a hearing problem. In addition, we looked at their general physical and mental well-being. Those in the experimental group received hearing aids immediately after the assessment, and those who in the delayed controlled group received hearing aids a year later. We followed both groups from baseline 6, 12, 18, and 24 months time. And so, in addition, they also underwent an MRI, FDG PET assessment, and we also did a health economic analysis. The study is completed, results have been analyzed, and I'm writing up the results. We hope to submit our manuscripts for publication very soon, and I look forward to sharing the findings with all of you within the next few months. So, because there are a lot of clinicians who are attending this presentation, I thought I'll share some practical tips they can take back to the clinic. When it comes to supporting people who are at risk of dementia or diagnosed with dementia, it's really important to emphasize the importance of attending the appointments with a family member or a caregiver. Getting the family and caregivers involved in the appointments is really important because you can then get additional feedback on hearing difficulties. You can do that formally using formal assessment tools or also using informal reports. So, when you're providing information about the clinical appointments, reminders, and rehabilitation options, it would be really great if you can use written information so that, in case they forget, they can always refer back to the written information. And now, as we are dealing with the aging population who could be at risk of dementia, it's important to have clinicians trained on strategies, communication strategies for acknowledging dementia, and to empower them and encourage them to inform their GP or the physician if they observe any change in memory and ask for a formal assessment that is suitable for hearing loss. When it comes to device selection, it's important to consider devices that are easy to use with simple controls, discuss rechargeable options, and encourage them to leave cochlear implants or hearing aids in a spot of regular activity, or using a bright colored bowl or case that seem to work really well with our clients. Especially when it comes to talking about cochlear implant candidates and recipients. During their journey, we have seen many of our cochlear implant recipients go through the stages of dementia. So, incorporating cognitive assessment in a CI candidacy test battery would be helpful, and also using devices that are simple to use, and also using the devices that can have objective mapping techniques would also be helpful. So with that, I've come to the end of my presentation. Thank you all for listening. And if you have any questions or would like to be part of the work that we do, here are my contact details.